Good evening, everyone, and welcome to the Together We Build Birthing and Neonatal Intensive Care Virtual Town Hall. This is the fourth in a series of conversations focused on the planning and design of 11 program-specific areas of the new Windsor-Essex Acute Care Hospital. Before we begin, let's respectfully acknowledge that the Windsor Regional Hospital occupies the traditional, ancestral, and contemporary lands of the Nishu, Iskoden, Anishinaabe, the Three Fires Confederacy, Ojibwe, Ottawa, and Potawatomi. We acknowledge the land and the surrounding waters for sustaining us, and we are committed to protecting and restoring these lands and waters from environmental degradation. On behalf of the project management team overseeing Stage 2 planning of the new hospital, we are pleased to welcome everyone joining us tonight via Zoom webinar. I'm Allison Johnson, Manager of Communications and Community Engagement for this project, and your moderator for tonight's conversation. Tonight, you will have the opportunity to meet some members of the user group designing the neonatal intensive care unit. And on an important side note here, throughout this conversation, you will hear the neonatal intensive care unit referred to as the NICU or the NICU. So I just wanted you to be aware of that. You'll also have the opportunity tonight to learn about some of the planning work that's taking place in these areas and to ask questions. The Q&A portion will take place at the end of tonight's presentation, but you're welcome to ask questions at any time. And you can do this by clicking the Q&A button at the bottom of your screen and typing in a question. We will do our best to answer as many questions as possible, but please note the focus of tonight's conversation is Stage 2 planning for the birthing and the NICU. And this includes items related to the physical structure of the department, its layout, what other programs and services are located nearby, design features, and technologies. So basically, how can we design these units so that they are patient and family friendly? And in order to maintain the flow of this conversation, please do ensure that your questions are related to this topic. Following tonight's conversation, we also invite you to visit our engagement platform at togetherwebuild.wrh.on.ca. And there you can ask further questions, you can take our surveys related to planning in these areas, and you can share your ideas. And now it's my pleasure to introduce everyone to our panel guests for this evening. Everyone, please welcome Rosemary Petrakis, Vice President of Women's and Children's Services, Deb Parent, Director of Women's and Children's Services, Dr. Greg Hazen, Chief of Obstetrics and Gynecology, Dr. Sajid Augustine, Medical Director of the NICU, Faith Nazdoldi, consultant with Agnew Peckham Healthcare Planning, and she's been working very closely with this user group. Kristen and Eric Lamar are patient reps for this user group. Dr. Andrew Petrakis is Director of Clinical Services Planning, and Paul Landry is Project Director for the new Windsor-Essex Acute Care Hospital project. Thanks everyone for being here with us tonight. And we're going to turn things over to Paul Landry to kick off our conversation with a look at the timeline for this project and what's involved in the current stage of planning. Paul?
Thank you, Allison. I'd like to start off by thanking the community participants that are joining us this evening for this virtual town hall. We want you to know that your questions and your input are very important to us and valuable to us as we are headed into the planning and the development of the new hospital project. I'd also like to say that it's certainly an honor and a privilege for me to be a part of the planning for the new Windsor-Essex Acute Care Hospital. The first slide that I'd like to present to you is simply an overview of the remaining 4 stages of the planning and development process for a new hospital project. We are currently partway through Stage 2, and I'll give you a more detailed overview of that in the next slide. But essentially, it's the development of a functional program, which we are currently working on and reporting to you on this evening. And the second part of that Stage 2 is to take that functional program and with a new team of architects and engineers that will be onboarding this summer for them to develop block schematic plans, which is really the arrangement of each and every clinical department and all support service departments into a new hospital building that will start to take a shape amassing form onto the site. The third part of the stage 2 is to update the preliminary cost estimate that was presented in stage 1. And of course, we received approval from the Ministry of Health and the government to move into stage 2. We'll be submitting the stage 2 early next year. The ministry will then review it and provide us, we hope in short order, approval to move into stage 3. Stage 3 is actually the development of indicative schematic plans, plus the development of procurement documents to go out to the market. We go out to the market in stage 4 to recruit a developer who onboards a contractor, subcontractors, and another design team to take our indicative schematic designs developed in stage 3 and further them into, excuse me, working drawings to be able to construct the project. Once we've agreed on, the guaranteed price for the project and it's approved by the Ministry of Health and Treasury Board following stage 4, we would then be beginning construction in stage 5, which is essentially the development phase of the project. If all goes well, in terms of the work that we have to do in stages 2, 3, and 4, and the review processes between those stages, we anticipate to be able to put the shovel in the ground in the summer of 2026 with an approximate construction timeframe of 4 years, and hopefully we'll be opening the doors of the new hospital in the summer of 2030. The next slide is simply an overview of this stage 2 that we are in presently, the development of the functional program, to be followed then by those block schematic plans and an updating of the cost estimate, all to be submitted to the ministry early in 23. I'd like to point out that we are working with approximately 40 user groups split between all of the clinical areas and the support service departments. We've onboarded 15 patient representatives in, of course, mostly the clinical areas, but also to include one for the public areas. And they'll be able to, some of our patients are with us tonight, patient representatives, I should say, and they'll be able to share with you their experience at the planning table. We have had 2 rounds of meetings. We have reviewed the first of 3 drafts, so there's still work to be done. We haven't finalized all of the number crunching, the forecasted volumes, and final decisions on numbers of beds and numbers of procedure rooms and the specifics, but we're headed in the right direction. We're just not able this evening to confirm detailed numbers with you. We will by summertime, and our intention is to have another round of town hall meetings in the fall, and at that time we will have more detailed information to be able to share with the community. Now I think I will hand it back to you, Allison, for.
Thanks, Paul. And as Paul mentioned, we do have patient reps working with us on some of these teams, but they're just one voice. And we do encourage you to add your voice to this conversation throughout the conversation tonight and also on our engagement website. And we're going to put that link in the chat section for you so you can head there after. If you do have any questions, again, throughout tonight's conversation, please type them in the Q&A and we will address those at the end of tonight's presentation. The first question of the night goes to Dr. Andrew Petrakis. Paul mentioned the 40 plus user groups. Dr. Petrakis attends most, if not all, of these meetings and has a good sense of what's going on. And the first question for the night is, what is included when we talk about birthing NICU? And then how does that fit into the big picture of what's being planned for the new hospital?
Good evening, everyone. I'd just like to echo what Paul has said in short form, I hope, on behalf of all the functional planning groups. I would like to thank the participants from the community for being here this evening. And we really look forward to you sharing your comments, suggestions, and questions regarding the planning of birthing in NICU for our new hospital. To get a little bit more detail, birthing in NICU encompasses caring for women during their pregnancies, care of newborns, and care of those newborns who require specialized care in the neonatal intensive care unit. Included in planning are the clinics that care for patients before delivery, and I'll give you a few examples. The pre-admission clinic, OB triage, women's health clinic, ROGAM injections, high-risk assessment, and IV infusions. As well, development of the new labor and delivery suites, LBRPs, C-section rooms, and the state-of-the-art NICU are part of this functional planning agenda. As Paul said, there are approximately 40 functional planning groups, each deciding upon distribution of services, space requirements, workloads and staffing specific to their departments. But there is an interchange of information because each of these functional groups don't actually operate independently. There's exchange of information when there seems to be information that needs to be passed along to other groups to make sure that all groups have their wishes and requirements met. There are several other things that we do discuss in great detail, and this is the relationship between actual areas within the birthing area and the NICU. What are the relationships between these clinics, the birthing area, and the labor and delivery areas, the NICU, and the C-section suites? All of this is taken into consideration when we do our functional planning. And there's other important adjacencies that we have to consider to make the family experience and the birthing experience as pleasant and as family friendly as possible. These relationships include the relationship of the birthing area and NICU to the emergency department, to pediatrics, to critical care, to the operative suites, and especially to the area where patients are coming into the hospital from the parking area, to make it easily accessible for these patients and their families to get to the areas that they need to get to. Thanks, Allison.
Thanks, Dr. Petrakis. Now, Rosemary, over to you. I want to ask you, how will the birthing in the NICU in the new hospital be different from what we see in the current facility?
Well, when you look at the current facility, we're at the Met Hospital on the 2nd floor, and we occupy the full city block. And on one end, on the north side, we have our GYN, antepartum, and clinics. On the east end, you have your high-risk deliveries with your section suites there. In the south side, we have NICU, and on the west side, we have our labor, birthing, recovery, and postpartum rooms, sort of spread out all over. In between, we've got sleep rooms, offices, staff lounges. In the future site, I see that when patients and families walk in, they're greeted by an administrative desk or what we used to call a nursing station or a command center. And from there, it's hallways or almost spokes where the different areas will be. So it will be connected by a central station. I mean, that's my vision, what the architects will come up with, but they all have to be in close proximity. The high risk, the low risk, NICU, our C-sections, and our clinics that support pre and postpartum care. But mostly is the ideas and our vision of what needs to be in those rooms. It has to be family friendly for the mothers, for the dads, for the visitors, and for the baby. What's going to go in the room? All the rooms are going to be single room. Our model of care is single room maternity care. What's going to be in those rooms so that the family's comfortable to care for the mom, to care for the babies? And then, like Andrew said, how accessible is it to support services? We're talking about having a satellite pharmacy that's shared between the pediatrics and NICU. How close is diagnostic imaging? How close is emergency room, or how close are we to the parking lot? And what kind of elevators are we going to have going back and forth to get our patients up and down to the support services? So a lot of different changes coming. And back in 2001, 2002, 2003, when they were building the current space we're in now, we've learned a lot. We've lived in it. We see where the changes need to be.
Sounds like a lot of conversations happening inside this user group. A question for you, Dr. Hazen, how do the decisions that are made in the conversations that are happening at that table, what impact will they have on the moms and dads that come into the hospital to deliver babies in the future?
Well, I think as Rosemary is iterated there, is that I think an easy, quick access for one to get into the hospital for assessment, especially in emergencies, getting to OB triage where we can assess patients in labor or questionably in labor, or patients that are having concerns with problems in pregnancy. So there's not confusion getting into being seen, but close access to the areas where we may need to send them. Some cases can be managed easily just as an outpatient. Some need immediate delivery when they come in like that. And we want to have the ability to access that in a comfortable environment, though, as well, as Rosemary has stated.
And similar question for Dr. Augustine. How will these benefit the families with babies in the NICU?
Yeah, thank you, Alison, for that question. The new hospital will mean families who come to our hospital and who would be using our services will not only have a state-of-the-art experience in terms of advanced medical technology, but it's also hoped that their experience is less stressful, or at least limited. We all know a stay in the NICU or an ICU can be difficult for many families and incredibly stressful. We know that. And that's why we are building a new NICU in a way that we hope will provide not only comfort, but a very pleasant experience and also limit their stress. Now, what is also important in the design of this new state-of-the-art NICU is the safety of the babies who will be staying in the NICU will be paramount. Not only would we look at reducing infection, but we will also look to optimize round-the-clock monitoring of these babies. We also hope to support the best outcomes for these babies. We know from medical literature that the experiences that our babies have in the NICU not only impact their stay in the NICU, but also their long-term brain outcomes. We are hoping that the very pleasant experience in the NICU would support long-term outcomes even after discharge. And finally, it's all about the family. How satisfied are the families in the NICU and the space where their babies are staying? Do they have privacy for pumping? Do they have privacy for breastfeeding? So to optimize all these metrics is something that we are looking to design in a very scientific manner, not only based on engineering principles, but also based on medical literature.
It sounds like a big opportunity for people, for the entire staff who, this isn't necessarily the work that you do every day, but an opportunity to make the work that you do every day and the patients that you see every day, make it easier on them. We're going to bring Faith Nazdoldi into the conversation now. Faith is from Agnew Peckham, and if you've been joining us for any of these, you know that Agnew Peckham has been part of some of the largest and most recent hospital builds right across the country, including here in Ontario with the new Oakville Trafalgar and Humber River Hospital. And she is now going to share some of the planning work that this group has accomplished so far, and also talk about some of the trends that her team is seeing when it comes to birthing and NICU in other hospitals. So Faith, I will turn it over to you.
Great. Thanks, Alison. Just maybe to open up a bit, and I will start sharing my screen right away. but I am going to talk a little bit about functional programming in general, and then get into some of the early work that we've been doing with our planning team. I would also like to say that it's fantastic to be part of the team working on this project, and I'm very much looking forward to continuing with the team over the next phases of design as well. Okay. I'm having trouble. All right, we'll do that. Okay. So really quickly, just to back up a little bit, functional programming, I like to consider as being sort of the backbone or the spine of everything that happens in the next phases. So we have to describe in words what the architects translate in design, and basically form follows function. So what we're talking about is how things work in the hospital and in the various departments, and then the architects build the design on that basis. Just to this slide, really, there has been quite a few changes in the way that we're planning hospitals over the last 20 years in particular. And a lot of it has been driven by what's been going on with infectious diseases and change in infection prevention and control practices. So the functional program, as Paul already alluded to, will include the services at the hospital. We've got our over 40 planning teams working to plan for various departments. We'll talk about the flows, workload and staffing, so how patients, staff, and materials flow through the hospital, adjacencies of the departments, and the detailed space lists that go into each functional program. There are 2 planning timeframes. We're looking at 2028-29, as well as 2038-39. So our hospital is, because of some of the delays with the Ministry of Health approvals, our hospital, we normally like to set the timeframes at the opening date. So as Paul said earlier, our opening date is really around 2030. But hopefully in most departments, the ministry is actually going to allow us to plan to that second timeframe, the 2038-39 timeframe. And as Paul also mentioned too, the block schematic plans, the work that the architects are going to be doing will build on the functional program, and that work will be starting later on in the summer. So in each functional program, in the program that we're doing right now for the birthing services or the perinatal services and for the NICU, we talk about the functions. So what services are provided? What are the inpatient services we're providing? And then what types of clinics are we also providing? We talk about the key operational processes. So we describe how a patient flows through the area. We describe how staff work in the area, how materials flow through the area. We also describe, for example, some of the relationships to the support services that are required in the areas. Workload, again, so this is really, in our case, for the inpatient areas, it's beds. It's the number of admissions to those beds. For clinics, it's visits. So we list the current, and then we work with the projected requirements, and that's how we get to build the space. Staffing, again, current and future staffing, and this helps us to define the numbers of offices and workstations that we're going to need for the future. In the next section, it's the planning and design requirements, and we are talking about the key departmental adjacencies. So Dr. Petrakis has already mentioned some of those for the birthing area and for the NICU, but it's really who do we need to be near to in order to provide the services that we need to provide. So it's like the surgical suite, like the emergency department, the relationship between between the birthing areas and the NICU, and as well as pediatrics. And finally, the space allocation. We do a room by room list of all the spaces that are required. And we tend to plan the space in the order that we want the architects to plan it in. So how somebody would walk through the department, or how everything needs to be organized. In terms of some of the trends and considerations, we, I mean, family and patient-centered care is always foremost. And we are, you know, we do see different models of service delivery, but for the birthing center, we are continuing with the proven excellent model that is currently provided at Windsor Regional. But one of the big things that has changed even in the last 20 years is the size of the labor, birthing, recovery, postpartum rooms have gotten even bigger. So there's much more space for the supportive families in those rooms, and much more comfortable for that environment. Infection prevention and control. Again, we need to consider the number of airborne isolation, labor, birthing, recovery, and postpartum rooms that we're planning. In the past, that was something that really wasn't considered very much, but now we are taking into consideration if a woman's coming in with COVID, for example, and in labor, then we have the proper environment for her to deliver that baby. And of course, operational efficiency. As Rosemary mentioned, we've got, we want to make sure that we plan the clinical areas adjacent to each other, and the ones with the key relationships closest, so that we're reducing the sneaker time of staff walking between areas, and we're making sure we're using the most efficient, the best use of staff. Okay. Just this is just a very high level diagram of the model of service delivery. So as Rosemary mentioned, we have our LBRP model. We have patients coming in through triage assessment, and they may go to an operative delivery room if required, then to recovery and back to the LBRP. And then we also have women that might come in for short stays before they go into labor. And that is where we'll have our antenatal stays, as well as some of our gynae surgery patients will also be staying in that unit. I don't know, this might be a little bit difficult to see, but this is what we call a bubble diagram. And again, we're still working through this with the team. So this is just an example, but here we are showing the birthing center, and the patients and visitors would come in through our central reception communication area. And then here we're just showing our clusters of the various types of spaces. So we have our assessment, triage, and induction area, including some of those, some of the outpatient services that are also delivered from that area. We have our operative birthing area. So that's our C-section rooms, so to speak, our high-risk LBRs, which are located closest to our operative birthing area, then our LBRPs. And then all along, we have shared staff support and staff access from a different location than from the patients and visitors coming in from the central reception and communication area. We're just showing the NICU here just to demonstrate how important that relationship is between the NICU and the area, particularly often to the operative birthing area and our resuscitation room, getting babies back and forth between those two areas. The antenatal unit is more like a standard inpatient unit, like a room that you would see on a medical surgical unit, for example. Again, we have a communication center. Then we would have our beds, our bedrooms, shared support, unit support for the staff. And then we have another area that really, it's a shared area for all of the areas. So that's where more of our administrative offices would be that support the birthing center and the antenatal unit. On to the NICU. Again, patient in terms of trends and patient and family-centered care, again, top priority. There has been gradually over the years a trend towards single room care. So as there has been in adult ICUs, there is a tendency to have the patients in a private room. And along with that goes windows and daylight for every bedroom. And there's been many studies that show how important that is for the neonates. Infection prevention and control, also primary importance, operational efficiency, and planning for flexibility, for example, for twins. So we talk about how rooms need to be connected so that if someone has twins, a mother can, or the family can get easy access between the rooms. So room can basically open up so that there's twin care. In terms of the patient and family-centered care, just to add, so we also think about the support spaces that we need to plan for the families in the unit. So it's not just about the babies, but it's also making sure that we've got the supports for the families because they spend so much time on the unit when they're babies in the neonatal intensive care area. This is just a really high level diagram. And again, it's something that we're still discussing with our team, but this just gives you an example of a pod of bedrooms for the neonates. So you would have a central communication station with each of the bedrooms surrounding, and you would have visibility to each of those rooms. So these are the kinds of things that we're going to be getting into the nuts and bolts and discussion over the next during our next meeting, our next two meetings in particular. And just to give you again the same bubble diagram as we did for the birthing area. So for the neonatal intensive care unit, we have our reception, entry, and control. And it is a locked unit so that you have to be basically buzzed in, you have to be approved to be able to enter the unit. We have a family support area, so family lounge, consult room, those kinds of spaces, our care by parent rooms. And then our clusters are our pods of bassinets. So here right now, I'm showing them as 3 pods of 8 bassinets, but again, that's still under discussion. And then we have our shared areas between the pods. So we have our main communication center. We have all the rooms that support the neonates, your soiled rooms, your clean supply, all those kinds of areas. And I don't have an ending slide. That is my last slide of the presentation. Thank you very much.
Thanks, Faith. Thanks for that presentation. And if anybody has any questions for Faith or any of our panel guests, please get them in. We're going to get to questions very shortly. But first, I want to bring in our patient reps into the conversation. Thank you both for being here with us tonight. And we'll start with Kristen. As a patient rep, you do bring an important lens to this conversation. How has your experience prepared you for this experience?
Thank you so much, Allison. And thank you everybody for letting us be a part of this amazing development. We obviously our hearts were touched by this NICU, and our experiences have been pretty extensive in terms of the care that we received. So I work in the human service field professionally. So I assist individuals in vulnerable populations with inclusivity and empowerment daily. So to be on the other side of that receiving sort of hand is a very different perspective. And it was interesting to kind of take part in it from that perspective. So my past is positive because I have an amazing son, but I have utilized many services, both at Met and in London, in our battle for fertility. And I'm grateful for my journey because it has brought me to where I am today. So I've had many gynecological surgeries prior to getting pregnant. In 2018, I had a stillborn and was admitted, which I received excellent care. So I've given birth as well. I've had many surgeries. I've had emergency surgeries prior as well. But when I was pregnant with Ace, my son. I had an emergency surgery, as well as I was hospitalized antenatally in Windsor. So I was antenatally for 87 days, both between Windsor and London. And I also received outpatient care in London via a condo, and London sort of looked after me as well. So I kind of have that perspective on London's care and what they offered as opposed to Windsor. So I can kind of offer that sort of perspective. We were admitted to the NICU. We spent 12 days in London. So we saw how the NICU ran, how the rounds were, how the pods were set up, the centralized monitoring that they utilized, kind of what the care was after my C-section, my emergency C-section. So we can kind of compare that with Windsor, and I'm able to offer that perspective. We then spent 47 days in the NICU, and I can't say enough good things about the staff and my experience there. I attribute the health of my son to Dr. Augustine and the staff there, and I can't say enough good things. So we had an amazing experience. We stayed both at the Ronald McDonald House in London and Windsor, so we can offer that perspective as well. We are ready to kind of help other families have a similar experience, if not better, hopefully. That hopefully we can give a perspective to kind of help them to have a better experience than we did, if that's even possible, to be honest with you. So I consider myself extremely lucky to be able to give feedback. I attribute the reason my son is here is because of the amazing staff. I'm fortunate to be able to give feedback so other parents can have similar experiences. And I'm fortunate to be able to be at this table. So thank you very much, everybody, for letting us share our ideas and our perspective.
My next question, maybe you both want to take a stab at this one because you've been through this together, but what considerations do you think are most important for the team to consider when working through the design of the new NICU?
Eric can answer this. I mean, he really, he could take that step back. I was kind of the mother that was sort of the mothering. And Eric kind of has some really good ideas on how you can be inclusive. So.
Yeah, thanks, Allison. And thank you, everybody, again. Yeah, besides the ongoing exemplary care that is going on currently at the hospital, I believe the inclusion of the entire parental unit is a top priority. We all know families come in many forms, and allowing easy access for the entire parental unit helps minimize stress during this very difficult and uncertain time. Having the Ronald McDonald House on site also as another great feature. It ensures peace of mind for the entire family, so that you're not worried about your loved ones, going through a dark street in the middle of the night or braving the cold in the middle of winter. Knowing that they'll be safe, and it allows you to get the limited sleep that you are going to get during that difficult time. Also, being part of this process early on, I can tell that every aspect of the patient experience and care is definitely being considered with the lively discussions that we're having, and everyone's level of care about what's going on is top notch. And that really the family consideration is priority one. So very thankful to be a part of it.
Thank you for being a part of it. We will go now. One more question. I do want to bring Deb into this conversation, and I do want to ask you, why is it important to have the patient perspective at this table, the perspective like Eric and Kristen and everybody who's participating online? What information do you hope to hear from them?
Well, I think you gave me the easiest question, so thank you, because Eric and Kristen just answered it for me. So I think they said it perfectly well. It's about the patients, about the family, it's about the staff, because they all have to work together. So it doesn't matter what Deb Parent thinks is going to work. Deb Parent's not a nurse in the NICU. Deb Parent doesn't have a baby in an ICU. We need the families and the staff and everybody that's actually in there to tell us what's going to work for them. So I think that Eric and Kristen were an amazing asset to this team, and they said it perfectly for me. So thanks, Eric and Kristen.
And a challenge for everyone on the other end. We need some harder questions for Deb tonight. So make sure you get your questions.
Whoa, no, Deb's good.
So in addition to tonight's town hall, we really do want to invite you to visit our engagement website at togetherwebuild.wrh.on.ca and provide your input. Everything that Deb mentioned, everything that we heard. What else do you think we need to think about when planning this and other areas in the hospital? On the site, you can have your input into 11 different planning areas. So please take a visit. And let's now go to some of our questions for the audience. The first one, I will ask Rosemary. Rosemary, will a Ronald McDonald House continue within the new facility or the adjacent property?
So yes, so we are working with Ronald McDonald House. They are their own functional team. And we are planning with them and just working out the space and the design. And we have community partners and community members on that team. And it's really looking at, will Ronald McDonald be part of the inside of the hospital, or will it be adjacent with a quick access to the hospital? So we are working on that. That's all part of our process. Ronald McDonald has been almost 10 years with us now. When Ronald McDonald and Windsor Renal started the discussions, that was part of the discussion, knowing that we were going to be moving to a new site, a new hospital, and were all in on this journey with us because they knew at the time 10 years is sort of the life expectancy before they start redoing and remodeling their Ronald McDonald House that they currently would be in. So they're partners with us, and we're holding hands on this journey together. So yes, they will be coming with us.
Thanks, Rosemary. Next question. How do single rooms impact your nurse patient ration or model of care? I don't know, Rosemary or Faith, if you want to take that.
Or Deb can pipe in too, but currently in our family birthing center, we have single room maternity care. So the staffing will stay the same. If our beds go up, then the staffing would go up. And not only our staffing isn't based on the beds, it's based on the acuity of the patient. You can have one patient that will, especially a mom in labor, or you could have one really sick postpartum mom that's your patient assignment, or you could have 4 couplets, a mom and a baby as a postpartum assignment. So it all depends on the patient acuity, not on the number of beds.
And so I'll add on to that, and similar for the NICU, which is why we're still too early to really be answering how the pods and how that's going to look for staffing. Obviously, it's going to impact our staffing. But it also depends on the acuity of the babies. So we're going to have a huge input from the families and the staff who are actually taking care of these babies as to what's going to work for the unit. So maybe in the fall when we're meeting again, we'll have a better idea how that's going to look. We'll have a better idea what the model's going to look like. Right now, still a little bit too early to look at how the pods will be set up in the NICU.
And maybe if I can just add to that quickly, I mean, even for the NICU, because we could be providing often one-to-one or 1-to-2 care, or if your ratios are a little bit higher, if we have the unit properly organized, there shouldn't be any real impact on staffing.
Thanks, everyone. A question from Ilana. Ilana wants to know how many beds will there be in the NICU? Dr. Petrakis, you have your hand up.
Well, I put it up and I put it rapidly down. The current number of beds in the ICU are I believe, 21. But based on population and demographic projections, that number will be increasing. But that's what we're currently going through with the functional planning group right at the moment. When we come back to you in the fall at our next town hall, we will certainly have much better grasp of what the bed numbers will be.
And I think Dr. Augustine wants to add to that.
Yeah, so if someone is looking for a firm number, so the current projections are by the end of this decade, so by the time the hospital is ready to open, we are looking at around 24 beds. And next decade, so the end of say 2038, 39, we're looking at 26 beds. And again, as Dr. Petrakis alluded to, this would entirely depend on population growth. And ideally, we would like the NICU to be at 70% capacity. So if you have 10 beds, only 7 beds should be occupied. Anything more than that is not ideal. So these beds are based on that.
Thank you. Next question I will address to Faith. Faith, are we planning to have a blood sample transport system for the NICU and emergency areas?
Yes, so I believe, Paul, we are planning pneumatic tube system for transport of blood to the laboratory. We're not relying just on robotics, are we?
No, we are not. And I would agree with that and confirm that.
Yeah. And that robust pneumatic tube system will be throughout the facility, also including the cancer center.
Thanks. A question for Dr. Hazen. When the layout discussed triage and clinical entrance, does that mean OB triage remains separate and not part of the emergency department?
I would say ideally, yes. Most of the patients that we're seeing that are coming to triage, at least early pregnancy, and especially more importantly, late pregnancy, it's better for us, and we think better patient care, more timely care to be assessed by an obstetrician. So the triage would be, OB triage would be in our own area, separate from emergency.
Thank you. Rosemary, are there any community programs or services that impact NICU, like fertility clinics and surrogacy programs that should be considered for future impact?
So I'm going to have to bounce some of that to Faith when we're looking at our projections and how we predict how many patients we're going to have in the future. And I really can't answer about the fertility clinics and how it impacts our program, because we just know the patients that come and their length and the stay of the patients. We don't know where they come from, right? So Faith, when we're planning the number of beds and the number of services we're going to have, how do you predict the patient population numbers, 4 or 5 years from now, and then 10 and 15 years from now?
So it's based on the Ministry of Finance population projections, and they update those every year. And they also do it by age group, so 0 to 5, 5 to 10, and on. And then when we so that's part of the information. And then we also use, obviously, the local data in terms of the records of the patients that are presenting at your hospital. So that's factored in as well. So it's based on that growth. But I guess maybe just to say there is the growth in the younger age groups is not as fast or as high as it is in the elderly population. And I think that's a trend that we have overall in Canada. Just add one thing, but immigration and emigration is also taken into account. So if there was young families coming into the area, that would also be considered.
Okay. All right. Well, it looks like we're at the end of our Q&A for tonight. If anybody has any further questions, once again, I will ask you to visit our website, togetherwebuild.wrh.on.ca, and you're welcome to continue the conversation there. I want to thank everybody who joined us tonight, everybody who's been joining us all week. We've had some great conversations, and we're back here next week. Next Monday, same time, same place, we're going to have a conversation about surgery. So please join us for that. Continue to share your thoughts. I I do want to talk about what will happen after this town hall series. Once we have all the results in, we're going to summarize them and we're going to share them with our planning team. So all of the surveys, all of the ideas that have been posted online, and your input will help guide the decision-making throughout the process. So please, again, take the time and participate. And then later on next year, as Paul mentioned, we're going to do this all again, and you'll have a chance to see how the planning has progressed and how your input has been used in that planning. I want to thank again everyone who joined us tonight, and a big special thanks to everyone who participated as a panelist throughout the whole week. It really is important that the user groups get to share the work that they're doing, and that they get to hear from you in the audience as we move through this process. So with that, we've promised the last word of the evening to Dr. Hazen, who's been fairly quiet this evening. So Dr. Hazen, over to you.
It's very unusual. Well, thank you for taking part in this. I think it's important for the community to have a voice and to actually take part in the planning of this hospital, because your perspective is certainly different than our perspective as the healthcare providers. You're the users of the program and the hospital. And I think your input is vital. I think Kristen and Erica really voiced that very clearly. And I think it's important for people to get involved. Thank you.
Thank you. Thanks, everyone. Have a good night.
Night, everyone.
Right now.